So you can start now. It's live.
Okay.
Achit,
Sir, sir.
we can start, okay?
Okay, sir. Very good morning, everyone. Uh, Myself, Dr. Achyut, DRNB resident in Medicover Hospitals, High-Tech City, Hyderabad. Uh, at the outset, firstly, I would like to thank Dr. Gansham sir and Dr. Srinivas sir for giving me such a wonderful opportunity to speak on this Tuesday morning. As a part of toxicology series, I would like to present regarding rodenticide poisoning today. So let us start off with the topic by some historical points, historical perspective from the pest control to the poison control. It was in the year 1911, zinc phosphide first used in Germany as a rodenticide. Aluminum phosphide in 1940s, it was introduced for grain preservation as it was cheap, effective. It was widely used in India. 60s and 70s, coumarin derivatives like warfarin, superwarfarin became common for rodenticide poisonings. In the modern era, yellow phosphorus used as rodenticides, as it is also found in matchsticks and firecrackers, it is largely misused as common suicidal poisoning. So, what began as an agricultural ally has become a public health enemy now. Broadly, it can be classified, all the rodenticides can be classified into metal phosphides, elemental phosphorus, anticoagulant rodenticides. Metal phosphides include zinc and aluminum phosphide, elemental phosphorus, yellow phosphorus, and anticoagulant based rodenticides like coumarins, warfarin, rodifacon, bromadiolone, etc. There are some other compounds which are also used as rodenticide poisonings like strychnine, thallium, arsenic, and sodium monofluoroacetate. Section 1, aluminum phosphide poisoning and zinc phosphide poisoning. These are some of the pictures of aluminum phosphide tablets, powder, which are available in the market. So they come under the trade names like phostoxin, Cellphos, Quickphos, Pimitoxin, Radol, Gastoxin, etc. We all know about Cellphos, a very notorious rat poison, which is considered as a very deadly and lethal toxin. Coming to the epidemiology, it has obviously it has high incidence in countries like India, Iran, Southeast Asia, where suicides are more common. Accidental ingestion can be seen in children, farmers, and household exposure. But mortality correlates with the amount of the uh, poison which is ingested and presentation to the hospital. The more delay, the more mortality, early hypotension, or arrhythmias. Source of exposure, agricultural fumigants, like some of these compounds are used to prevent the pest infestations in warehouses and store downs. Rodenticides, obviously tablets, pellets, which are used in households and farms. Occupational and accidental, like in inhalation in ventilated areas. Coming to the chemical structure and mechanism, both aluminum phosphide and zinc phosphide, when they are ingested and when they come in contact with the water and hydrochloric acid, a very deadly phosphine gas is released, which is rapidly absorbed, which binds to the mitochondrial cytochrome C oxidase, which inhibits the oxidative phosphorylation. Subsequent cellular consequences like ATP depletion, oxidative stress leading to lipid peroxidation, and finally multi-organ dysfunction. So this is a schematic diagrammatic representation. The phosphine gas at the center, which causes all the effects like decreased G6PD, decreased catalase, decreased oxygen uptake, hypoxia, decreased cytochrome C oxidase, ultimately resulting in tissue injury, multi-system failure, and death. So these are some other cellular events at the mitochondrial level, at the cellular level, which can cause the ultimate tissue injury and death. So coming to the lethal dose, alpha's lethal dose 0.5 to 1 gram tablet, as low as one pellet can also kill a person. Zinc phosphide 4 to 5 grams. Mortality can go up to 90% in aluminum phosphide poisoning, despite if the patient is given adequate ICU care. Poor prognostic factors if the patient has persistent hypotension, metabolic acidosis, ECG changes, LV dysfunction, and if he presents delayedly more than 2 hours after the injection, the prognosis gets more poorer. The mechanism of toxicity of zinc phosphide is similar to the aluminum phosphide, as it also releases phosphine gas when it comes in contact with gastric HCl. But the effects of zinc ion also has some effects like direct mucosal irritation, which can cause vomiting, abdominal pain, pancreatic inflammation, which can rise amylase levels and pancreatic necrosis. But the onset here in zinc phosphide is delayed, like 2 to 4 hours post injection, when compared to uh, aluminum phosphide, which can cause an multi-organ effects, cardiovascular like myocardial depression, hypotension, arrhythmias. Respiratory, it can cause cardiogenic as well as non-cardiogenic pulmonary edema. Metabolic like lactic acidosis, hypoglycemia, electrolyte imbalances. Renal, AKI, secondary to shock, hypotension, and rhabdomyolysis. Hepatic transaminitis and centrilocular necrosis. This is a diagrammatic representation of all the organs which are involved from the brain, starting from the brain to the kidney, with the cellular mechanism. Pediatric considerations, very lower dose can also be lethal to children, like 10 to 15 milligrams per kg alphos can be fatal. It has a faster progression in children. It can develop shock and metabolic derangements within 1 to 2 hours. Clinical signs like vomiting, hypotension, bradycardia, etc. Monitoring required is continuous ECG, invasive BP monitoring if the patient is hypotensive, and early urine output monitoring to quantify the seriousness of AKI and renal failure. So the most common entity, the most common organ which can kill the person is obviously the cardiac toxicity. It is the killer. It causes direct myocardial depression by decreased contractility, refractory hypotension, global LV hypokinesia. The EF can get reduced to as low as less than 30% also. The mechanisms are myocarditis, microvascular spasm, and direct cellular hypoxia. So these are all the effects of the heart, like congestive heart failure, shock, palpitations, refractory hypotension, cardiomyopathy. Pericardial effusion is also possible. Coming to the lungs, it can cause non-cardiogenic pulmonary edema because of capillary leak due to phosphine-induced endothelial injury, ERDS development. We can see the bilateral infiltrates both in the chest X-ray and the CT images. Ventilation, obviously, it is a challenge when in the settings of severe hypoxemia and severe ARDS, like we have to follow the ARDS ventilation strategies of lung protective ventilation with low tidal volumes and high pressures. Metabolic derangements, yes, lactic acidosis because of phosphine-induced mitochondrial inhibition and anaerobic metabolism. Electrolyte imbalances like magnesium, potassium, and sodium, as already discussed, and hypoglycemia, particularly in pediatric cases. The phosphine gas affecting the mitochondria and electron transport chain. It depresses the mitochondrial complex activations, mainly 1, 2, and 4, which reduces the ATP production and the further consequences of cellular injury and cellular death. Hepatic and CNS manifestations, it causes elevation of enzymes, coagulopathy, and hepatic encephalopathy, CNS confusion, agitation, and coma. Same mechanisms everywhere, like hypoxia, mitochondrial injury, and ammonia accumulation. Monitoring can be done through serial LFT, serial ammonias, and serial coagulation profile. The different stages of aluminum phosphide poisoning. Stage 1 is an early stage, that is 0 to 6 hours. Symptoms like early GA upset, vomiting, hypotension, and metabolic derangements can be seen. In stage 2, from 6 to 24 hours, there is cardiovascular collapse, including hypotension, arrhythmia, and pulmonary edema also. After 24 hours, which is a stage 3, there sets in the multi-organ failure, where the patient goes to the deathbed with renal dysfunction, CNS depression, and everything. So these are all the end organs mentioned in this diagram, like AKI, kidney, muscle injury, acute liver failure, hypoxic ischemic encephalopathy, and also ARDS. We'll discuss the role of CRRT, ECMO, and mechanical ventilation in the coming slides when the patient lands up in such kind of situations. There are some specific diagnostic tests like gastric aspirate silver nitrate test, like phosphine reduces silver nitrate, which can cause black precipitate, but it should be detected early, and there are also false negatives if it is delayed. Breath phosphine detection, highly specific but rarely available. Serum phosphine not routinely done. It is done only in specified labs. Obviously, cardiac biomarkers to quantify the level of myocardial injury, bedside echo to quantify the ejection fraction and LV function, chest CT chest to if there is an uncertain diagnosis or to evaluate complications like pulmonary edema or aspiration versus ARDS. Gastric decontamination. The most important thing is the gastric lavage should be done only if the patient presents less than 1 hour post-admission. Avoid if there is unprotected airway or there is a risk of perforation. It should be done by potassium permanganate 1:1000 or coconut oil is preferred, which will neutralize the phosphate gas release. Activated charcoal has limited efficacy, may be used as adjunct. Avoid sodium bicarbonate lavage, which because it increases the phosphine gas release. Zinc phosphide, everything is same. The most important thing which is special to the zinc phosphide poisoning is it causes pancreatitis. Pancreatitis is a hallmark. So elevation of serum amylase lipase should be checked for in the setting of zinc phosphide. Uh, this is a stepwise diagnostic workflow which can be initiated at the ER level till the ICU level. Step one is immediate, which should be done within minutes, like ABCs, focused history taking, time of ingestion, amount of ingestion, type of ingestion, and removal of the exposure, putting too large or IV cannulas, monitoring the vitals and all. Step two, within 15 to 30 minutes, initial basic investigations like ABG, lactate, glucose, electrolytes, LFT, CPC should be sent immediately. Step three, 30 to 60 minutes, chest X-ray, ECG, bedside echo should be done to assess the LV function and also to see for the urine output monitoring. Step four, confirmatory the confirmatory test for the poison which is ingested can be done by using gastric aspirate silver nitrate test, which where we can see the black precipitate or breath phosphine, or we can consult a toxicology expert for further confirmation. Triage decision, admit to ICU, there is hypotension, or if there is metabolic acidosis or lactate levels are more than 4, if the patient is having arrhythmia or PF ratios less than 200, or if feel that patient needs mechanical ventilation and airway experience. Some drugs like magnesium, they are also having a very good role in the prevention and control of arrhythmias. The dosage is 25 to 50 micrograms per kg IV. Maintenance is 0.5 to 1 gram per hour infusion to monitor deep tendon reflexes, respiratory rate, and ECG. Sodium bicarbonate has a role when the acidosis is severe, like pH less than 7.0 to 7.1, or severe hemodynamic compromise. 1 to 2 milliculents per kg IV bolus, then reassess EPG, avoid blind correction. There is an adjunct role of N-acetyl cysteine. The dosage is same as we use in the acetaminophen toxicity, 150 mg per kg in the first hour, 50 mg over next 4 hours, and 100 mg over next 16 hours. Evidence is limited but commonly used as an antioxidant therapy. The role of some of the other antioxidants are also studied, like N-acetylcysteine, vitamin C and E, trimetazidine, and melatonin. Dosages are given, but the strong supportive evidence is only studied for magnesium sulfate. All the other antioxidants have a limited role, adjunct role, and experimental role. Corticosteroids, routine steroids are not recommended. Hydrocortisone 200 mg per day IV in refractory shock if there is a suspected adrenal insufficiency. Insulin infusion for stress hyperglycemia. Antibiotics, no prophylactic antibiotics are implicated, but only if there is a suspicion of aspiration or secondary infection. GI protection through PPAR, H2 blocker, DVT prophylaxis, and early enteral feeds within 24 to 48 hours. If the patient is stable, we can start. Indications for mechanical ventilations, severe hypoxemia, ARDS, and altered sensorium if the patient is not protecting the airway. Ventilation strategy, as we discussed, it is a low tidal volume, 6 ml per kg predicted body weight should be used. PEEP of 5 to 12, titrate to oxygenation, and plateau pressure to be kept below 30 centimeters of water. Prone positioning in severe ARDS, neuromuscular blockade if there are high driving pressures. What about CRRT in phosphide poisoning? Yes, CRRT has a role in phosphide poisoning when there are indications like severe metabolic acidosis or refractory hyperkalemia or high lactate levels. Advantages of CRRT over the other modalities of dialysis like IHDR, it has a slow correction of acidosis and it maintains the hemodynamic stability, avoids rapid osmotic shifts when compared to IHD, and there is a continuous toxin clearance which has an indirect benefit because CRRT is continued for 24 hours all through the day. Effluent dose, the standard KDO recommended dosing of 25 to 30 ml per kg per hour using a citrate or heparin as an anticoagulant. This is a study. I mean, this is a case report. They have reported two cases done in Department of Critical Care Medicine, Max Hospital, Delhi. The conclusion of these two case reports were CRRT has an edge over intermittent dialysis in these patients, and it can be used in the cases of hemodynamic instability patients for prolonged duration, where conventional hemodialysis is relatively contraindicated. Furthermore, CRRT helped to maintain metabolic milieu and resolution of shock till alphas got excreted. Studies have shown that CRRT, which uses hemodiafiltration with convection as a principle, scores over hemodialysis, which is a diffusion-based therapy. Coming to the extracorporeal life support systems, ECMO, VA ECMO, considering VA ECMO for refractory cardiogenic shock with potentially reversible causes is indicated, but the conditions which should be fulfilled before taking a decision to initiate ECMO are the age of the patient should be considered, comorbidities, whether they are favorable or not for the initiation of ECMO, no irreversible CNS injury should be there, available resources and experienced team should be checked for initiation, and if the patient presents early to the hospital, then ECMO has a bigger role. VV ECMO for refractory hypoxemic respiratory failure, ARDS, if it is not responding to conventional ARDS lung protective ventilation strategies. ECMO is a rescue therapy. Coordinate with the tertiary center early if we are suspecting that the patient is going to land in a severe refractory cardiogenic shock. Early anticipation and coordination with the tertiary care center where the ECMO facility is available can increase the survival rate of the patient. This is a study published in Cardiological Society of India 2016. It's an Indian study. It's an observational study. They have observed the outcome of patients supported by ECMO for aluminum phosphide poisoning. The conclusion was VA ECMO has been shown to improve uh, the cardiogenic shock of the patients with alphos poisoning having severe LV myocardial dysfunction who have presented to the hospital earlier. Whereas if there is a longer delay in the hospital presentation, were found to be predictors of non-responders for ECMO usage. So the large, adequately controlled and standardized trials should be performed to confirm these findings further. High dose antioxidant protocol considered as some emerging therapy. Some antioxidants like vitamin C, vitamin E, 400 mg, ED, NAG has a role as studied. Selenium 200 micrograms per day also has been studied. I have tried to compile the literature uh, done from 2019 to 2023 regarding this antioxidant therapy. Uh, Supportive and magnesium sulfate has a survival rate of 30%, and high dose vitamin C, which studied in 2023, has a survival rate of 45%. And this is Indian data and outcome trends studied from 2020 to 2005 across all the reputed institutes of India. Uh, the higher sample size study was done in 2021 by AIMS New Delhi. Uh, uh, they showed that if there is a delay in presentation, if the patient presents more than 2 hours to the hospital after injection, the mortality increased up to the rate of 78%. There are some experimental antidotes. Obviously, there is no approved antidote yet. Several experimental agents are under investigation, like trimetazidine, methylene blue, acetylcysteine, melatonin, L-carnitine, etc. The common pitfalls in management are delayed gastric lavage or use of water because it enhances the release of phosphate gas, excessive fluids, which can cause pulmonary edema, ignoring hypomagnesemia, which can cause refractory arrhythmias, using adrenaline in isolation, which worsens the myocardial injury, late transfer to the tertiary care, which can miss the ECMO window, overlooking hepatic pancreatic involvement. Prognostic factors, early hypotension has a high risk of death, severe metabolic acidosis, arrhythmias, delayed ICU admission has a high risk of death. So coming to the next section, yellow phosphorus poisoning. These are some images showing the yellow phosphorus powder and the container. So it is also called as gratol paste used in firecracker industry. It is used as rodenticides, 3 to 5%, fertilizers, matchstick industry, etc. It is extremely lipid soluble because that's why it is having a rapid GE absorption. It is highly toxic, as little as 1 mg per kg can be fatal. Delayed toxicity, patients appear well initially. Major target organs are again liver, heart, kidneys, and GI tract. It is classified as a protoplasmic poison causing mitochondrial failure. Usually, intentional poisoning in India is common as it is used as a suicidal agent. Mortality can go up to 90% once hepatic failure develops. It exists as white, yellow, red, black, phosphorus, etc. Insoluble in water, but highly soluble in lipids. Hence, it accumulates in hepatocytes and myocardium. It spontaneously ignites in air at 30 degrees centigrade, emits garlic-like odor. Phosphorescent, it glows in dark after ingestion or in vomitus. Resistant to gastric acid, cyclical intrahepatic circulation, which is responsible for its prolonged toxicity. Toxicokinetics, rapid absorption from stomach, peak times within 2 to 3 hours. 80 to 90% gets sequestrated inside the liver. Protein binding is high. It has a biphasic distribution, phase 1, GI and blood symptoms, phase 2, hepatic storage, delayed injury. Metabolism, oxidation causes phosphoric acid plus reactive oxygen species, and excretion is through renal and biliary, but recirculation causes prolonged toxicity. The mechanism of toxicity, same lipid peroxidation, massive hepatocellular necrosis, myocardial damage, inhibition of the sodium potassium reductase pump, causing cellular swelling and multi-organ failure, leads to refractory shock plus fulminant hepatic failure. The clinical phases of this poisoning is phase 1, phase 2, and phase 3. In phase 1, it is the first 24 hours. Symptoms like vomiting, hematemesis, phosphorescent vomitus, and abdominal pain can be seen. And phase 2 is 24 to 72 hours. It is considered as a pseudo recovery phase. The patient appears clinically better with decreasing of the GI symptoms, but it is a deadly trap because there is an ongoing hepatic necrosis which will be presenting in the subsequent days. That is in the phase 3 in terms of liver failure. It can cause jaundice, coagulopathy, delirium, encephalopathy, AKI, shock, etc., which will have a high mortality. So the key point is to always admit the patient, even if the patient looks stable after 24 hours. Uh, Investigations. The basic investigations in the admission, LFTs, coagulation profile, ABGs, serum phosphorus level, rarely helpful. ECG, we can look for QT prolongation and arrhythmias. Predictors of poor outcome, INR more than 2 in first 2 hours, severe metabolic acidosis, marked AST and ALT elevation, and early onset of encephalopathy within 72 hours. Management overview, no antidote, early aggressive decontamination of the poisoning, supportive liver protection and ICU care, treatment of arrhythmias and shock, consider NAC early, benefit is suggested, avoid oily substances which can increase the absorption, evaluate for liver transplant in the setting of fulminant hepatic failure. Goal is to prevent progression to phase 3 liver failure. Gastric lavage, if within 1 hour of presentation, here also we can use potassium permanganate or copper sulfate, but controversial due to it itself can cause a toxic effect. Activated charcoal has a limited role. Avoidance of milk, ghee, and fatty substances because it enhances the absorption. Liver protective therapies like NAC in the dosing of acetaminophen poisoning. Vitamin E has limited evidence. Maintenance of euglycemia to prevent hypoglycemia. Target INR should be less than 1.5, glucose more than 100, and lactate clearance should be achieved. There is a role of Plex. Uh, this is a study done by Ernakulam Medical Center, Kochi, Kerala. They have studied the role of Plex in the patients of yellow phosphorus poisoning. What they have suggested is the proposed Plex initiation should be in the early stages before the hepatic injury sets in. If a hepatic injury sets in, and if we propose for the initiation of Plex at the time of post-hepatic injury and pre-transplantation, and there is a very risk or very decreased outcomes. But if the proposed Plex initiation is before the onset of the hepatic injury, survival rates are more better. Cardiac and renal support, we have to treat the shock with IV fluids and vasopressors, correct the electrolytes. continuous telemetry AKI. CRRT is also preferred if encephalopathy is present. Arrhythmias, antiarrhythmics like amiodarone and is preferred. Avoid lidocaine or digoxin. The criteria for liver transplant referral, King's College criteria of ALF like INR more than 6.5 respective of encephalopathy or INR more than 3.5 plus creatinine more than 3.5 plus encephalopathy 3 to 4. Persistent lactate more than 3, worsening bilirubin and acidosis despite therapy, mortality more than 80% without transplant in fulminant stage. Prognosis: if the patient progresses to stage 3, very poor survival, early ICU transfer improves outcomes. Delayed coagulopathy again is a poor sign. The causes of death may be due to refractory shock, ventricular tachyarrhythmias, acute liver failure, and metabolic collapse. Survival depends on early aggressive management in first 24 to 48 hours. Coming to the final section, coumarin based pesticides like warfarin, superwarfarin, etc. The mechanism is vitamin K antagonism, require only one injection to cause toxicity. Onset is delayed 24 to 48 hours due to depletion of the pre-formed clotting factors. Patient often presents late after bleeding starts. The toxic compounds can be divided into two generations, first generation and second generation. First generation is warfarin and comachlor. Half-life is 20 to 40 hours. Repeated exposure is needed for the toxicity. Second generation, superwarfarins like brodifacoum, bromadiolone, difenacoum, 60 days to 9 months. Extremely potent lethal toxin. Among these, brodifacoum is most common in India. It is also lipophilic, stored in liver plus adipose tissue, which is the reason for prolonged therapy. Mechanism of toxicity: it inhibits the vitamin K epoxide reductase enzyme, which prevents the recycling of reduced vitamin K, resulting in decreased gamma carboxylation of vitamin K dependent clotting factors 2, 7, 9, 10. Firstly, factor 7, which will cause the early derangement of the PT and NR. It also inhibits the protein C and S, which can cause transient early hypercoagulability state. End result is severe coagulopathy, spontaneous bleeding. This is the uh, representation where the vitamin K dependent clotting factors become inactive to 7, 9, 10. The pharmacokinetics: highly lipophilic, accumulates in fat and liver, enterohepatic circulation, reason for the prolonged toxicity, extremely long half-life. Brodifacoum has 16 to 270 days of half-life. Bromadiolone has 20 to 30 days. It crosses placenta, also has a risk to the fetus. Breast milk, also it is detectable. Therapy must continue until the INR normalizes for 2 weeks after stopping vitamin K. Clinical features of bleeding manifestations: epistaxis, complete metastasis, hematuria, massive bruising, intracranial hemorrhage, very life-threatening bleeding manifestation. Failure and tachycardia can be seen. Rare is respiratory distress when there is pulmonary hemorrhage, intraalveolar hemorrhage, diffuse alveolar hemorrhage, etc. Essential investigations: again, coagulation profile, blood counts, D-dimer, FTP, LFT, renal functions, baseline renal functions, etc. Optional, we can send plasma warfarin level, super warfarin level, or TEG in terms of massive bleeding settings. How can we differentiate this poisoning from other coagulopathies like DIC, ALF, and heparin toxicity? If there are normal platelets plus normal D-dimer, we have to think in the lines of rodenticide. Management principles: stabilize with ABCs, control active bleeding, reverse coagulopathy by giving vitamin K, BCC or FFP based on severity of the bleeding, long-term therapy, daily vitamin K for weeks to months, serial INR monitoring weekly. Do not give vitamin K prophylactically if INR normal initially, recheck the INR after 48 to 72 hours. If INR is elevated but no bleeding, vitamin K therapy, 10 mg IV vitamin K slowly, continue 10 mg oral daily, recheck INR every 24 to 48 hours. Severe bleeding or very high INR, 20 to 20 mg can be given as a stat, repeated doses based on INR. Key principle is to continue vitamin K until INR normal for at least 14 days after stoppage. Prothrombin complex concentrate is preferred, dose is 25 to 50 intention units per kg. Rapid INR correction. If it is not available, FFP 10 to 15 ml per kg can be given. Platelet transfusion is indicated only if the platelet count is less than 50,000 or patient is having very active bleed. PCC corrects coagulopathy quickly, but vitamin K is essential to sustain that correction. Duration of treatment for superwarfarins 4 to 6 weeks, 3 to 6 months, often 3 to 6 months, depending on the INR response. Weekly INR monitoring is necessary. Duration should be guided by the clinical improvement, stability of INR after stoppage of the vitamin K. Special populations, pregnancy, there is definitely fetal bleeding risk, aggressive vitamin K therapy should be given. Pediatrics, accidental injection, prolonged treatment is necessary. Chronic alcoholism, because of the baseline vitamin K deficiency, it worsens the toxicity even more in chronic alcoholics. Prognosis good if treated early, mortality low, except in settings of intracranial hemorrhage or delayed presentation with massive bleed. So key danger is stopping vitamin K prematurely, which can cause recurrent bleeds. Here, let us discuss a case scenario. A 35-year-old male consumed unknown amount of Ratol paste 10 to 12 hours. Uh, brought late, initially vomited at home, felt better now, progressive nausea, right upper quadrant pain, past history, nothing significant. Like by examination, the temperature is 38, heart rate 120, BP 95 by 60, patient is confused, icterus is developing, tender hepatomegaly, and he's oliguric. Labs on arrival at 12 hours, AST 450, ALT 380, bilirubin 0.5, INR is range, create 1.6. At 24 hours, now the enzymes are started to rise, AST 2200, ALT 1800, bilirubin 4.8, INR 2.7, ammonia 85, and lactate has been spiked up to 6.5. 36 hours, ALT is still rising, INR 3.6, worsening metabolic acidosis. Interpretation is the patient is going into rapid progression to acute hepatic injury with early coagulopathy, rising ammonia and lactate, impending acute liver failure. What should be the management strategy if such a kind of patient rolled into or steps into our setups? Critical care transfer. Move to ICU immediately. Rationale should be hemodynamic instability, encephalopathy, and oligo or anuria. Continue or escalate NAC infusion. Extend beyond standard 20-hour regimen. Discuss regarding the prolonged infusion with hepatology. Mitochondrial. The rationale of NAC is mitochondrial and antioxidant support. Hemodynamic optimization. Cautious IV fluid should be given. Avoid overload to prevent pulmonary edema. Start inotropes to maintain the MAP target of more than 65. Insert invasive lines. Correct hypoglycemia. Maintain glucose infusion. And coagulopathy management. Give IV vitamin K 10 mg. Prepare FFP if invasive procedures are planned or active bleeding is there. Renal support, early decision to initiate CRRT, given the rising creatinine level is suggested. Transplant liver, as the patient is landing up with acute pulmonary hepatic failure, immediate discussion with the transplant center as he meets early criteria, INR score 3.5, encephalopathy, and early listing, if possible, can help the patient survival. Complications to anticipate are DIC, sepsis, cerebral edema from ALF, raised ICP, refractory shock, arrhythmias. Possible outcome if patient progresses to grade 3 encephalopathy and is listed for urgent liver transplant with transfer and transplant, patient can be saved. Without transplant, prognosis is grave. So the key takeaways from all the four sections are regarding metal phosphides mechanism. The main entity is the phosphine gas. Lethality is extremely high, few grams can kill a person. Hallmarks are refractory shock, metabolic acidosis, ARDS, and myocarditis. Management, there is no specific antidote. Aggressive supportive care, vasopressors, ECMO is a good option in refractory cardiogenic shock cases. And the red mark warning. Avoid gastric lavage with water. It will release more phosphine and it will be more detrimental to the patient. Yellow phosphorus, direct hepatotoxicity, acute liver failure, clinical course is painless vomiting, followed by a latent period, then again hepatic failure after 3 days. Key clues are luminous vomitus, garlic udder, and delayed jaundice. No antidote again, repeated gastric lavage with potassium permanganate or copper sulfate, early liver transplant referral, and acute hepatic failure develops, patient can be saved. Coumarin derivatives mechanism is vitamin K dependent clotting factor depression. Onset delayed 12 to 24 hours. Symptoms are again spontaneous bleeding, coagulopathy, hematuria, epistaxis, etc. Treatment is vitamin K, prolonged therapy may be required. If required, in the setting of active bleeding, FFP or PCC can be given. So the funda is early recognition, aggressive support, and prevention. These three remains the pillars that can save lives in patients who come with rodenticide poisons. Thank you. Thank you so much.
Hello,
Yes, sir.
Srinivas sir is there.
Uh, yes, sir.
Uh, Srinivas,
Mike
thank
issue.
you. Thank
Yeah,
you, Achyut.
yes, I'm here. Yeah.
Okay.
So this is a important paradigm, and as we have discussed in the previous session also, profile of poisonings in India is changing from organophosphates and established things. We are now seeing more and more of these ones. There is a misconception that the mortality is very high irrespective of what you do. There have been times before the ECMO actually started where we have managed these patients very aggressively with CRRT, pacing, and supportive care, and with reasonable success. So, as has been mentioned during the talk, early identification, appropriate risk stratification, and transfer to the right center with the expertise is probably very important, and public awareness needs to be created. And we do not yet know the role of extracorporeal toxin removal in the management of phosgene gas related rodenticides. Maybe in future we may have some options on that front also. So,
Thank you, Achyut. I think it was a very good presentation. Very crisp to the point with each section. Though all are rodenticide poisonings, sometimes, I mean, the mechanism of action and the toxicity is different for each agent. As Srinivas said, I mean, we have seen both aluminum and zinc phosphates very early in our careers. Uh, Still, certain parts of the country have a very high incidence of these toxic incidences. Yellow phosphorus, you have to be a little careful. I had the personal experience of managing a couple. They look absolutely stable when they present initially, and the rapidity with which acute liver failure sets in is very dramatic. I mean, they look very, very stable in the first 24, 48, 72 hours, and suddenly you'll find the INR has gone up, liver enzymes are gone to the roof. So you have to do it. Otherwise, excellent presentation, Cheers. Thank you very much. And any queries, please back to us. We will get back to the answers.
Thank you, sir.
thank you. And we will
Thank you.
Thank you, sir. Thank you, sir. Thank you, everyone. Can we leave the meeting, sir? I think we can leave the meeting, right? Right?